The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we're thrilled to have Dr. Jason Wellen here to review the management of all things transplant surgery, particularly liver, kidney, and pancreas transplant.
Thanks so much for having me. Happy to be here.
Dr. Wellen is a professor of surgery, director of Washington University's Kidney and Pancreas Transplant Program, and chief of pediatric kidney transplantation for St. Louis Children's Hospital. My name is Sydney Beache, and I'm a PGY4 and will be your host for this episode. Today, we'll be talking about transplant surgery. Specifically, we'll discuss the basics of transplantation, transplant immunology, technical considerations for transplantation, complications, and exciting innovations within the field of transplantation. Over 100,000 people in the United States are currently waiting for a transplant, with liver and kidney transplants being the most commonly transplanted organ. Transplant medicine and surgery are unique branches of medicine that can be a life-saving and life-changing resource for patients and families. So can you talk about the basics of organ allocation and types of organ donation?
Yeah, as you mentioned, Sydney, there's over 100,000 people waiting for kidneys. The largest wait lists are kidney transplants. And there's really two types of donors for some organs, really kidney and liver primarily, which are, there's either deceased donor kidneys or there's living donor kidneys. When we discuss kidney, the best type of kidney that someone could get that's going to have the longest half-life is going to be a living kidney with an average half-life of around 15 years, as opposed to a deceased donor kidney, which is around 9 years. And the wait times fluctuate depending on the region of the country you're waiting, that you live in. The wait times can be anywhere from 2 years in some parts of the country to upwards of 10 years in other parts of the country.
Well, thank you for giving that introduction. We can transition to the fundamentals of transplant immunology. Can you talk a little bit about HLA subtypes and their clinical significance, as well as the role of T cells in the adaptive immune response?
Sure. As most people know, particularly with organ transplant, we do our best to match blood types. We can do ABO incompatible organ transplants, but those are a little more complicated. So we generally try to match blood types. And the other thing that's important is HLA. And so everyone's cells have HLA antigens, and we all have HLA antibodies within our body. We do our best to match those appropriately to sort of reduce the incidence of acute rejection or even early rejection or even late rejection. And the main types of HLA that we focus on are HLA class 1, HLA class 2. We look at in terms of mismatching. It could be anywhere from, we generally break these down to 3 categories when we're getting an organ offer for a kidney. So it's going to be HLA class 1, and then you could either have 2 separate, an A subclass, a B subclass, and then we look at one form of HLA class 2. Even though there are many, we focus only on the DR. So it could be anywhere from a 000 or as upwards of 2 mismatch, 2 mismatch, 2 mismatch.
Understanding the basics of immunology help make sense of the medications that we use to prevent against rejection, which is a complication of transplantation that we'll talk about a little bit later in this episode. So what can you tell us about induction and maintenance immunosuppressive agents in transplantation?
So when we put an organ into someone, we generally have to immunosuppress them. Most of the drugs that we utilize today primarily focus on T cells. There aren't that many drugs that we're able to give our patients to protect them against B cells, which is really who's going to make the antibodies. So most of the drugs we use focus on T cells. Like you'll notice in the Washington Manual book, there is induction agents, and particularly in the kidney transplant world, there's monoclonal antibody or polyclonal antibodies. The monoclonal is really basiliximab, which is the main one given, and that's an anti-CD25. So it's just an antibody against one specific binding site. as opposed to antithymocyte, which is a polyclonal antibody depleting induction agent, and that has many different antibodies that work on many different receptor sites throughout the body. After the induction agent, then we have to give a maintenance immunosuppression regimen, which could be usually a cocktail of drugs with an anti-proliferative agent. Many centers do steroids. About 30% of programs throughout the United States are steroid-free. And then there's other classes of drugs like calcineurin inhibitors or mTOR inhibitors as another maintenance drug. And those patients will be on for the remainder of their life, and we'll check drug levels or trough levels.
Now for a brief overview for the technical aspects of transplantation, obviously, we know that the field of transplantation is very complex, but we'll do our best to distill the major operations into 5 steps or less if we can. If we could start with liver transplantation.
Sure. A liver transplant is an orthotopic transplant. And what that means is we take out the old organ and we put the new one in the exact same spot. So things like heart, lung, liver, those are orthotopic transplants. And if I was to break down that operation, the first step is to remove the old cirrhotic liver. And that's really one of the more complicated aspects of this operation. There's often been ascites and potentially peritonitis. They have portal hypertension, so a lot of their very small veins are actually quite enlarged. So that's the first step, is to remove the old liver. Usually at the same time or similar, you have another team of surgeons going to get you your new liver. So there's the organ procuring of your new liver from your donor. And then another phase is you have to prepare that liver on the back table. You have to tie off branches, oversew bleeding sites before you put it into the new patient. And then the next phase is implanting that new liver. And you have to sew really the vena cava. There's a few different ways to do that. There's either piggyback technique, bicaval technique, or you could put someone on veno-venous bypass. Then you also have to sew in the portal vein and the hepatic artery. And then you have to sew in the bile duct. And that can either be done with a connection of the duct to the recipient's duct, or you could build what's called a hepatojejunostomy and use a piece of intestine to connect to the new donor bile duct.
We'll transition to the kidney transplant in 5 steps or less.
Sure. Kidney's different. Kidney's a heterotopic transplant. So we never actually go anywhere near the recipient's old kidneys. We put the new kidney in a totally different place, ideally in either the right or the left lower quadrant through what's called a Gibson incision. So we put the kidney retroperitoneal. And similar, you have to get the kidney out of the donor, whether it be a deceased donor or a living donor. You have to clean the kidney on the back table, same sort of method, oversewing branches, removing unnecessary tissue. And then the third phase is implanting the kidney, where we place it in the retroperitoneal space, and we sew the renal artery, ideally to the external iliac artery, the renal vein to the external iliac vein, and we sew the ureter of the transplanted kidney to most commonly the recipient's bladder.
And then we have the pancreas transplant.
So a pancreas transplant is like the kidney. It is a heterotopic transplant. We never actually go in and remove the recipient's old pancreas. It is often done either through a midline incision or 2 separate right and left lower quadrant incisions. But ideally, most people perform it through a midline incision. Same kind of thing. You have to take the pancreas, usually out of the deceased donor. You have to prepare it on the back table, which is a very complicated portion of that operation. You sew on what's called a Y graft, which is really the common iliac, external, internal iliac bifurcation from the donor. You have to prepare that onto the new pancreas by sewing this Y graft onto what's called the SMA and the splenic artery. And then you implant that kidney, and generally it's done also underneath all the intestine. And you generally sew it if you're going to do what's called systemic drained. You'll sew the portal vein of the pancreas to the inferior vena cava, and you'll sew that common iliac artery portion of the Y graft. You'll sew to either the external iliac artery or a common iliac artery of the recipient. And at this point, the pancreas is perfused and hopefully starting to make some insulin, which is the main reason we do a pancreas transplant. but you do have to get rid of the exocrine function. And most centers now, about 80 to 90% of centers do what's called enteric drained. And so that will be sewn. The duodenal segment of the pancreas will be sewn to a piece of the recipient's intestine so that they can defecate out the exocrine function.
So we have our patient who's had our transplant operation, and our hope, as you said, that we have a good graft function afterwards. But let's transition a little bit to talk about complications following transplantation. So we mentioned rejection briefly in the context of talking about immunosuppressive agents. Can you talk to me a little bit about the 4 types of rejection?
Yeah, there's 4 types of rejection. The one that we don't really see much anymore is called hyperacute rejection. Because we've gotten so good with matching HLA and not doing as many ABO incompatible transplants, we really don't see that much anymore. There's acute rejection, which is something that the people we have to look at really for the whole first year of their kidney transplant. It happens in about 10% of kidneys in the first year. We're almost always able to get them through that. With some of the new medicines that we're able to treat them with. There's chronic rejection, which is something that they'll have to look out for over the whole course of their life. And that could take years, if not decades, to develop chronic rejection. It's usually a slow process that occurs over time.
And then after that, we also have an accelerated rejection, which was something that was relatively new to me. But accelerated rejection occurs within 1 week of transplantation, which is also within that group of types of rejection.
Yeah, some of our patients are very complicated. At our center here at WashU, about 20 to 30% of our patients are second or third time transplants. And while we do a really good job of trying to measure their HLA antibodies that they may have, there's so many things floating around them that sometimes there's things we don't even know to test for at the current time. And those are the patients that we could see what you're referring to as almost like an early, it's not hyperacute, but it's an early acute rejection. And so these are deemed high-risk patients, and we kind of are careful when we transplant them, knowing that there's a risk of this.
So in addition to rejection, patients who undergo transplantation are also at risk of developing opportunistic infections. What are the most common opportunistic infections we see in this population?
Right. So there's the usual things like you or I can get, any common colds, GI bugs. But then there's other things that are really much more prevalent in the transplant population. And these are viruses that you and I and people listening probably have. But because we're not immunosuppressed, it doesn't really cause a problem. The main ones are cytomegalovirus, CMV. So if you have a patient whose labs are not looking right or the patient looks ill, you always have to check for CMV in these patients. Another virus that all of us are probably carriers of is something called Beache virus. And that's something we see in kidneys often. It usually affects the uroepithelium. So, and you can measure it in the blood, or you can even measure it in the urine. And look at BK viruria, BK viremia. So if they're acting sick or ill, that's another thing you can look at on these patients.
And then we also have complications that are specific to a specific organ transplant. For example, liver transplantation. Some of the common complications that we might see in that population: hepatic artery and vein thrombosis, biliary strictures, and then kidney-specific complications like lymphoceles, arterial venous thrombosis, or urine leaks. The final piece that I have is a little bit outside of the scope of board's preparation, but I'd like to close the segment by talking about exciting new advancements in transplantation, particularly integrating robotics into the procurement operation and into the transplant operation. And I would love to hear about the future of minimally invasive transplant surgery from you.
Right. There's a lot going on in the transplant space right now. If you look at the kidney transplant world, besides there are always new drugs coming out to fight these infections, from a surgical standpoint, robotics has really become into play. And many centers have been performing their living donor nephrectomies laparoscopic, but many more are now switching to a robotic platform, which has really been great for the patients, and it's been a real advancement. Moreover, we're actually even implanting many kidneys now robotically. And those are done usually through an intra-abdominal incision as opposed to a retroperitoneal approach. With regards to innovations in the liver world, it's even more so. Kidneys have always had hypothermic perfusion pumps available, where we pump these kidneys through cold preservation solution. Now in the liver world, we are now pumping many livers with warm blood, with normothermic machine perfusion, NMP is what it's called. And that's really allowed us to use that pump to determine if a liver is suitable for transplant, and also really able to move liver OR times. So it's not uncommon, we'll pump livers for 10, 12 hours. So rather than starting liver transplants in the middle of the night, we're able to do them in the morning. So it's been great from a work-life balance standpoint.
Absolutely. I'm sure many of your colleagues would agree. Well, thank you so much for being here with us today. We got through a ton of great information about transplantation. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of transplantation can be found in the Washington Manual of Surgery. Thanks so much for your time, Dr. Wellen. We really appreciate it.
My pleasure. Thanks for having me.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.